So just to kind of bring us up to date, so as George showed, the last chemotherapy FDA approved was really in the 70s. We've made some progress since then, but it's really been just since the late 1990s and early 2000s where you can see that we've had introduction of some targeted therapies. And what I mean by that, so targeting a molecular signaling pathway, which may be more specific to tumors. So it's targeting a pathway that's involved in tumor growth. So this is sort of an alphabet soup of different receptors and different molecules in these signaling pathways. I'm going to talk a little bit about some of them. The first group is are some angiogenesis inhibitors, and just to give you a little sort of tip, anything that ends in an AB is an antibody, and anything that ends in an IB is an enzyme inhibitor or a tyrosine kinase inhibitor. The antibodies tend to be IV drugs, and many of the tyrosine kinase inhibitors are oral drugs. So angiogenesis as a target for neuroendocrine tumors or cancers in general is interesting. So here we have some tumor cells. They will secrete angiogenic factors or signals that then will sort of target the blood vessels and then stimulate further tumor growth to cancers. And so tumors themselves have a very disorganized group of blood vessels. And angiogenesis inhibitors, we theorize, can work in a couple of different ways by either organizing blood vessels better to tumors, in a sense to helping to better deliver chemotherapy, but they may also block blood vessel growth. So truly we don't really know yet how these work, but those are the two leading theories. So why in neuroendocrine tumors do we think angiogenesis inhibitors might be effective? Well, if you look at the two panels on the left, so thinking back to Dr. Kwan this morning was talking about CAT scans. So these are those cross-sectional images through the chest and abdomen. Here we have the liver. And these panels on the left represent typical metastases in a colorectal cancer. You can see that they look dark or hypodense. That's in contrast to the panels on the right, where you can see that the metastatic spots in the liver are bright. Those indicate, with IV contrast that goes to those tumor spots, that they are hypervascular. And so the theory has been that, well, neuroendocrine tumors are very hypervascular. Maybe they would be an excellent target for angiogenesis inhibition. So there are a couple of different strategies for targeting this pathway. So VEGF, mentioned up here, is a vascular endothelial growth factor. These are little cartoons where the cell is located here, and there are receptors on the cell that and those receptors can then signal this molecular signaling pathway. And they can be blocked in a number of different ways. So for example, bevacizumab, an antibody, also known as Avastin, actually blocks, that's this green, represented in green as the antibody, can actually block a protein that normally goes to the receptor, and then that blocks that whole angiogenesis pathway. Another mechanism for blocking it is an antibody that blocks the receptor itself, thus also blocking that entire angiogenesis pathway. A third mechanism is blocking the intracellular pathway, and some of those IBs that I mentioned, sunitinib, sorafenib, pazopanib, actually block the intracellular signaling pathway. So I won't go through lots of detail on these. You have this in your handout, but only to say that many of these have actually been tested in phase 2 clinical trials. I'll target a few of them, but bevacizumab or Avastin has been looked at in phase 2 studies. Primarily, this particular study looked at just carcinoid patients and was done by Dr. James Yao at MD Anderson. And again, the endpoints were looking at response rate and progression-free survival, and had a progression-free survival of about 14 months. And remember, phase 2 studies don't necessarily have a comparator. They're often just a single arm of treatment, but enough that this was promising and has since gone on to phase 3 study. That's what the asterisks mean. Sorafenib, likewise, has been studied in phase 2 studies looking in both carcinoid and pancreatic neuroendocrine tumors by the Mayo Clinic. Sunitinib, I'm going to spend a little bit more time focusing on because that's one of our sort of new hot drugs that I think is one of the next drugs to be FDA approved. And then pazopanib, likewise. So this is a study that really has just been presented at our big oncology meeting. We have one, it's called ASCO, the American Society of Clinical Oncology. We have it every June. So we tend to get new announcements about exciting drugs at this meeting. And in this particular study, it was a phase 3 randomized study that took 171 patients with well-differentiated pancreatic neuroendocrine tumors. And as George mentioned, these newer studies are much more rigorous in terms of eligibility criteria. So these patients had to have had progressive disease before getting enrolled in the study. They were randomized to get sunitinib or Sutent, a pill that everybody took daily, versus patients who took a placebo pill. The primary endpoint was progression-free survival. This study was started back in 2007 and was actually stopped early because it looked to be quite effective, that the treatment arm looked to be more effective than the placebo arm. And a lot of these studies have sort of an early look built into the study just to get a sense of safety and early efficacy in case they do need to stop these studies early. And this is, well, it's showing up better up there. So the progression-free survival curve, as you can see along the x-axis here is in months, and the y-axis is the probability of survival. Sunitinib had a progression-free survival of 11.4 months compared to 5.5 months for placebo.
So just so everyone knows, that's not survival. It's 11.4 months before 50% of the people had growth of their disease.
Correct.
So I don't want anyone to put themselves in that picture. It's a very statistical term that doesn't apply very well to the individual. It just says the population took longer before it started to grow.
Right, absolutely. So that goes back to this whole point that George was getting to earlier, that it really delays the progression of the disease. This does not at all refer to overall survival, and it doesn't actually correspond to tumor shrinkage. So moving on, angiogenesis inhibitors with chemotherapy, that's something else that's being investigated. Many combinations are being looked at. So Temodar, temozolomide with Avastin, that's being looked at Dana-Farber in pancreatic neuroendocrine tumors. And then some of these other studies are mixed. And as George was implying earlier, it's hard to know. Some of these mixed studies will get these sort of hard to interpret results, but that's often how the phase 2 studies are started. So a study at UCSF, they along with Stanford, we've done similar studies looking at a combination of chemotherapy plus Avastin, and these two studies are very similar. I'll talk about ours in a minute. And then a fourth study of cyclophosphamide, which is a chemotherapy plus one of the tyrosine kinase inhibitors, sorafenib. So I think that the main point of this slide is just to say that I think that the direction that a lot of the newer treatments are going in are trying to look at how can we make chemotherapy more effective, and I think that that direction is adding some of these new targeted agents. So I'll talk about the Stanford study just briefly. So we've just completed a phase 2 clinical trial of 40 patients that looked at a combination of 2 chemotherapies. That's capecitabine or Xeloda, which is a pill, plus oxaliplatin, which is an IV chemotherapy, and bevacizumab or Avastin in metastatic neuroendocrine tumors, so all types. So it was a mixed group. We did not require progressive disease before coming on study. And our endpoints included sort of a smattering of some of the things that George talked about earlier: progression-free survival, toxicity, overall survival, and response rates. So just to show you, we had about half of the patients enrolled had pancreatic neuroendocrine tumors and then a smattering of others. As you can see, the pancreatic neuroendocrine tumors, as has historically been true, had the best responses. So we had 6 patients with partial responses, and what that means by true clinical trial definition is that those patients had 30% or more shrinkage of certain target lesions that we followed, sort of spots in the liver or spots in the lungs. 11 patients had progressive disease, but in looking back, many of those patients actually did have progressive disease prior to coming on study, and I'll show you a sort of graphical picture of that in a few minutes. So if we tally this all up of all the patients that had partial responses, you can see here that there were 7 total out of the 40 for 18% total that had partial responses. But many patients, 25 of those, had stable disease, many for quite some time, up to 27 months on study. And so you can imagine that that's actually a clinical benefit if we can stabilize previously growing disease, even if we don't shrink it. So we felt that the rate of disease control or clinical benefit was around 80%. This is just a sort of visual of some of the responses that we could see. So this again is a picture of the liver with the hypervascular liver metastases prior to coming on study, and then after a certain period of time on treatment became quite a bit smaller. Another interesting observation that we've made in a few of our patients is that a number of patients will have ascites or fluid in their abdomen that's associated with the cancer. This is actually not something that's very easy to put a ruler on, and in fact is not formally included as part of a clinical trial response, but as you can imagine, if you could improve that for a patient, would provide a great deal of quality of life improvement. And we've seen a number of patients had decrease of their ascites. So that ascites is this sort of moderate gray color next to the liver that you could see prior to going on the study, and became markedly improved on the treatment. So a waterfall plot is a way, sort of a static way of looking at responses. Each of these bars represents a different patient on the study. Below the 0 line is shrinkage, so any negative number is considered a good thing. And then above 0 would be considered growth. That's sort of the best response that any of these given patients had on study. The yellow is what I mentioned as partial response, anything more than 30%. And in blue is anything between 0 and 30% shrinkage. So as a visual, the large majority of the patients on this particular study had some degree of shrinkage as their best response. However, the one disadvantage of this, it's sort of a single point in time. It doesn't really give you a sense of how these folks did over the, say, months that they were on treatment. So as an alternative way, we're trying to figure out other ways of looking at this information, of a more dynamic way of evaluating this. So in this particular graph looks at weeks on treatment. Each line is a different patient. These are only the patients here who had partial responses. The vertical line here represents time 0 when they started the study. And here you see patients, many of whom had growth before going on study and then shrinkage over time. Again, these were all the folks, so many, as you can see, did have growth before going on and then a degree of shrinkage. Some folks had stable disease for months on treatment. These are the folks who had stable disease on study. So again, many of them, as you can see, had a little bit of growth, but were able to maintain a degree of shrinkage for quite some time. So George and I have been working with some statisticians to try to figure out better ways of visually depicting growth, particularly in tumors that tend over time to be slower growing. And this, we feel, is a better representation than that waterfall plot, which is just a static measurement. I'll mention, so moving on along sort of a little further down the line of some of the signaling pathways, we'll talk just briefly about some other new drugs. So everolimus and temsirolimus are mTOR inhibitors. These are a new class of drugs, well, not new, but new to cancer treatment, actually. So mTOR stands for mammalian target of rapamycin. It's a lot easier to say mTOR. And it plays an important role in signal transduction pathways, so those molecular signaling pathways that I showed the picture of earlier. It also is involved in proliferation, cell proliferation, and angiogenesis. And they're currently approved right now for treatment of transplant rejection. So sirolimus is in that same family, and it's also currently approved in treating kidney cancers. So everolimus, or RAD-001, is a drug that's being actively investigated in neuroendocrine tumors. So there are a number of phase 2 studies, again this is more for your sort of reference later, that have been very promising, both in carcinoid tumors and in pancreatic neuroendocrine tumors. Everolimus in particular, there's sort of a series of trials called the RADIANT trials, and that stands for RAD-001 in advanced neuroendocrine tumors. I don't know who comes up with all these great names, but many clinical trials have catchy names, so that's that. So everolimus has then gone on to phase 3 studies. So I'll mention the phase 3 study because there are 2 phase 3 studies that are ongoing. In fact, I think both of them are going to be updated in a couple of weeks at a European conference, so I don't have all of the data on those. But the RADIANT-2 study is looking specifically at carcinoid tumors. So again, it's a more defined group of patients as opposed to being mixed. It's planning to look at 390 patients with advanced carcinoid. Again, disease progression was required, randomized to everolimus plus octreotide versus octreotide plus placebo. So the word on the streets is that this is looking promising, but I don't have the details of that information. That will actually probably be out in about the next month. A similar study is looking just at a defined population of pancreatic neuroendocrine tumors. So a similar population in the sense that or similar numbers, 400 patients, advanced pancreatic neuroendocrine tumors. Again, disease progression is required. And this is looking at just everolimus versus placebo. Just to kind of back up a second, the reason, remember, George talked about octreotide as an anti-proliferative or decreasing progression-free survival for patients with mid-gut tumors, and that's why this has been included in this particular study. So we do have a preview of the pancreatic data for everolimus, and it looks like, again, this progression-free survival or delayed growth of tumors also occurs with everolimus, so I think that that's very promising. This, again, will be updated in a couple of weeks at the European meeting. So there are a couple of proposed studies that are also very exciting. So if we can combine some of these targeted meds with chemotherapy, why should we be looking at combining them together? So there is a randomized phase 2 study looking at that RAD-001 or everolimus versus everolimus plus Avastin. Another study that we are actually or in the process of developing and opening at Stanford is the combination of the Temodar-Xeloda plus Avastin. George mentioned Temodar-Xeloda as being a very promising new combination of chemotherapies, so we plan to add a targeted agent to that. And then looking at sunitinib in carcinoid. The phase 3 that I mentioned was sunitinib in pancreatic neuroendocrine tumors. A few ongoing other studies that I will not, other phase 3 studies that I won't go into the details of, but other targeted meds, chemotherapy combinations. So just to conclude, I think that this is amazing that in a rare tumor there have been at least 3 phase 3 studies completed in the last year or so with positive results. So I think that that's I'm lucky to be the one to talk about this because I think this is one of the most exciting things in neuroendocrine tumors right now. So there was the PROMID study showing that octreotide is something that delays progression from mid-gut tumors. There is the sunitinib data and the RAD-001 data in pancreatic and carcinoid tumors, so all of which I think are very exciting. So I think that we're very soon to have 2 new FDA-approved targeted medications in these diseases. So I think that they're encouraging results. There are many, many different possibilities and ways of mixing and matching chemotherapies and targeted agents to do these studies, which is exactly why we have the NCI, or National Cancer Institute Task Force. There is a national group of doctors coming together to figure out what the national priorities are for asking interesting clinical trial questions so that we don't sort of have too many different trials going on and that we get the right questions answered. So I'll stop there.